Okay, hopefully you can hear me. I'm going to try and share my screen. So let's have a look. Are you able to see my screen?
Yes, Gerry. Yes.
Great. Okay, so I'm going to give you a quick run through of the gateway reviews and the interactive pathways which we've developed for a number of diabetes conditions, including the diabetic foot. So most of you will know about GIRFT. GIRFT is about reducing variation in care, not only in diabetes, but many other areas of medicine. Our GIRFT report was published in 2020 based on visits to 104 trusts around the country using data which we'd extracted from NADIA, the NDA and NDFA, and HES data to look at how trusts were performing, but also to ask them exactly what sort of services they had in place, and really to make some recommendations to individual trusts, but also to provide a report for the nation. We reviewed 3 areas: diabetic foot disease, inpatient diabetes care, and type 1 diabetes transitional care, and indeed in relationship to that, the use of technologies. Now, obviously, we couldn't cover the whole of diabetes, but today I'm just going to be talking about diabetic foot disease. So we've already heard today that there's large variation, and this goes back, this data goes back to 2012, and you can see that the West Country had a high amputation rate, and it was then suggested that this variation was most likely to be related to service provision. I'm pleased to say that this has been quite clearly demonstrated by Richard Paisley, who worked down in the Southwest. He identified 10 key requirements for an effective diabetic foot service. And using those 10 key elements, you can see that those who had less numbers in the red tended to have the higher amputation rates than those who had more of those key processes in place. But more than this, over the next few years, they changed services, and you can see that there were many more services with those key elements in place, and you can see the amputation rates significantly reduced. So I think this is not rocket science. This is something that we've been talking about for a long time, that you need to have the systems in place. And indeed, you know from what we've heard already in the NDFA, that the earlier someone is seen, the less severe the ulcer is likely to be, and severe ulcers heal much quicker at 12 and 24 weeks, and severe ulcers are associated with a less likelihood of admission, and a shorter length of stay. So again, I stress that this is pretty obvious to me, and indeed this is this influenced our development of the recommendations in NG19 about training primary care staff to identify those at risk, foot protection teams, rapid referral, including the access to vascular surgery, multidisciplinary foot teams, and all admissions to have a foot examination to ensure that people don't get into trouble whilst in hospital because they've not been identified as being at risk. So when we did our visits, there was clearly a lot of variation across the country. And as you heard, many places didn't have a multidisciplinary foot service. So that was our original GIRFT visits. Now we've got the GIRFT Gateway reviews. The Gateway reviews are slightly different. Here we do not just review the trust, but we review the whole system. And that's been really effective, talking to the trusts about their difficulties and identifying those to the system, so the system listens, and hopefully the system and the trust will work together to address the deficiencies. So far we've made 18 visits across the country. There are 42 ICBs, so we've got 19 left once we've done our final 5, which are booked in the early new year. So I talked about NG19. We've actually, in our recommendations for diabetic foot services, we've basically replicated them. So, and I'll come back to these in a minute. So we talked about multidisciplinary foot teams, integrated community foot care services. We added renal and dialysis units to be part of the surveillance, community protection teams, and also rapid access to vascular surgery. So what's been happening over the years? So this is data from Nadia. You can see in 2010, less than 30% of 30% of services did not have a multidisciplinary foot service. This remained largely unchanged until 2017, when Diabetes UK and Putting Feet First and Barbara Young raised a fuss nationally about this, and you can see there was an improvement. But since we've had GIRFT and the transformation funds from NHSE, you can see that all but 6 trusts have multidisciplinary foot teams. Having said that, we know that a lot of this happened from transformation funding, and in some ICBs that funding has not continued, so this may change. But part of our role as GIRFT is actually to influence the ICBs to make sure that the transformation funding is, once it's ended, that these services continue to be in place. So when we make our visits, we have data to present, and this data here comes from the model health system. And this, for example, is looking at major amputation rates occurring electively. And we discuss this data with them. So here, for example, is a trust which has very low levels of elective amputations. So a lot of their amputations are occurring as emergency amputations, and ideally you want planned amputations and not disasters occurring that suddenly have to go to amputations. Now this is expressed for the 42 ICBs. You can see 42 down here. That's across the 42 ICBs. The data can also be expressed across the provider levels. So these are 72 trusts who do amputations. As I said earlier, there are 130 odd providers, but not all do amputations. Of the 72, you can see where there's, again, this is the same trust. You can see where they rank. In this system, there's only one trust undertaking amputations, and so that's why provider level doesn't look much different to the ICB level. We can also track changes, and you can see over time the percentage of major amputations occurring electively has fallen. So they're going in the wrong direction. This looks at length of stay for the major amputations, and again, this ICB is at the extreme end. They have an extremely long length of stay, 36 days. And so in presenting this to the ICB and trust, we ask whether they've got any thoughts as to why that might be, and we encourage them to look into this. And you can see, again, in this trust, the median length of stay is actually going up. This looks at minor amputation rates occurring as day cases, and ideally they should occur as day cases. They're in the 3rd quartile. And in this case, the minor amputations are occurring at 2 trusts. Sorry, you can see the changes in minor amputations. But the minor amputations now in this ICB occur at 2 trusts rather than the major, which occurs at only 1 trust. And you can see that there is a variation between the two. This trust here has has a community pediatric surgeon, and that's why they have a high level of minor amputations occurring as day cases. So at the end of our review, we then produce a report, and this is an example of one of the reports. So the pediatric services were well set up, but there are multiple pediatric vacancies. There's funding, but there are vacancies. Integration with secondary care between the community and secondary care is very good, and virtual clinics are available at both. There's rapid access to vascular surgery. there is a problem around inpatient podiatry. The funding is at risk, and this is one of the transformation funding which has ended. At the non-hub site, surgery for non-vascular patients is a problem. So there's a 12-month waiting list for orthopedic surgery. There's no casting at Trust A and limited at Trust B. The ICB are aware of this and are going to review that service. As I've shown you, the percentage of amputations are going as elective is low, and this is one of the worst performing ICBs for mean lengths of stay. And we highlight the fact that this is going to cost the system quite a lot. So in summary, the ICB are encouraged to address the above issues in their planned system review. And I think this has been, these sorts of reports have been very helpful to both the providers of services and also the commissioners of service. So that's the Gateway review. The other things we do at GIRFT is to try and help people in terms of help them implement changes in services and come up with some innovations as to how we might do things differently. So we have developed these best practice pathways, and you can see that we've got the pathways in the emergency and admission units. We've got a discharge pathway, and we're now finishing an emergency surgical pathway. And these pathways have been developed by a group of healthcare clinicians, from nurses, podiatrists, from pharmacists, etc. So very multidisciplinary. Now, I've only got time to show you the foot pathway, and of course, that's all you're here to listen to. And this is what it looks like on paper. So presenting to ED, what is a presenting symptom? What are the presenting features which will decide on initial management? And then who should you refer them to? Can they be discharged and so on? So that's what it looks like on paper, which is okay. But if I show you some of the other pathways, they are actually a little bit more complicated than that in terms of the way when you view them on paper. So we were thinking about how we can make this really accessible to the junior doctor in the emergency pathway, for example, in the emergency department, for example, or indeed one of the nurses in the emergency department or the AMU. And we thought the best way to do this was to put this onto an interactive pathway, which could be accessible on an iPhone, an iPad, or you can get it on your computer. But the great thing about having it on an iPhone, for example, it wouldn't be blocked by the hospital IT system, which seems to be so common these days. So this is what our pathways look like. So we'll go into the foot pathway, which is here. Hopefully this will work. Okay, so here we have it. So management of the patients presenting to ED with a foot problem. So for all of the pathways, there's a little introduction here just to remind people that there are other things that can happen to people with diabetes. So click here to be reminded of the essential checks for everyone admitted to the emergency department. And we've got a little acronym here called SNAC and TICKLE. SNAC is make sure that the patient is fed, because they may have had insulin and not eaten, and they'll go hypo in your department. Think insulin for type 1 diabetes. People with type 1 diabetes, as you probably are witnessing, many patients staying 12, 15 hours in an emergency department corridor and not being given insulin and going into diabetic ketoacidosis. So that's important. Check ketones for people on SGLT2 inhibitors. Look at the feet to make sure that there's not an infection, and that's the cause of the temperature or the confusion that the patient has been admitted with, and examine for loss of sensation. So that's a little snack and tickle acronym, which should be used in every patient who comes into the emergency department. But let's go back to the foot. So presenting symptoms might be an ulcer and a wound or a red hot swollen foot. If we go to ulcer and wound, you can see it's broken down into 3 areas: gangrene, necrotizing infection, acute ischemic pain, or suspected abscess. So let's click on that. So we need a deep wound swab tissue sample before starting IV antibiotics and a foot x-ray. And this patient needs an urgent surgical review. Pretty straightforward. And they also need to be highlighted to the multidisciplinary foot team. So that's really very simple to follow. And so hopefully that will be helpful to your junior doctor in the emergency department. If, on the other hand, they haven't got these conditions, but they're systemically unwell with spreading cellulitis, again, exactly the same initial management, but these people need admitting and immediately referral to the multidisciplinary foot team. On the other hand, if they're not unwell with only mild infection or no infection, again, the initial management will be the same, but they can be discharged and referred the next day review by the multidisciplinary foot team. And you will know that many of these patients tend to be admitted. So this is a way of admission prevention. And if, on the other hand, we've got a red hot swollen foot with no break in the skin, consider Charcot as a diagnosis. Also, alternative pathologies, the initial management of foot x-ray, and immobilize must be non-weight bearing, and they can be discharged and urgent review by the multidisciplinary foot team within 24 hours. So I hope you would agree that that is pretty simple, and I hope it will be very helpful to those within the acute admission units. So I'm just going to end by saying that I think for various reasons, GIRFT and both NHSE have prioritized a number of areas, and the multidisciplinary foot team development has been one area which has been heavily invested into, which has been really beneficial. So I'd like to thank you all for listening, and of course the delivery of better care is due to many organizations. So thank you.